Thank you, co-chair and co-chair and distinguished audience. Namaste. In the next 10 minutes or so, I will be presenting the major lessons learned from a study, health sector policy responses and health workforce management during COVID-19 that we conducted, that the Herd International team, along with the team of Queen Margaret University, Edinburgh, and the Liverpool School of Tropical Medicine, conducted in the first wave of COVID-19. Starting with the brief overview, when the COVID-19 started in Nepal, Nepal's federalization was in its initial stage. Although the core functions of the three tiers of government were defined, however, the clarity in terms of execution of the roles and authorities were not yet fully realized, and there have been calls, especially from the local governments, for support in terms of strengthening capacities, and the local governments were delivering the basic health services, and this COVID-19 has further challenged the local governments to maintain the routine delivery of health services and respond to the COVID-19. In this context, we focused on one of the key elements of the COVID-19 response of Nepal, which is the health sector, which is the health workforce management. So the aim of our study was to describe the policy responses, health sector policy responses to COVID-19, and also to understand the processes of policy formulation, communication, and implementation, particularly focusing on the health workforce management. We adopted a cross-sectional exploratory case study using a mix of documents review, where we reviewed all policies, strategies, and directives introduced in response to COVID-19 in Nepal from January to December 2020, and we adopted qualitative methods where we interviewed 22 key informants from January to March 2021 at the local, province, and federal level. The list of informants are shown in the table. We chose two municipalities in Kapilvastu district. For this study, ethical approval was sought from Nepal Health Research Council, and we use in vivo software for coding and thematic framework analysis approach for the analysis of the study findings. So many of you have been familiar with this framework, which was also presented by Professor Sophie Witter yesterday during her presentation while she was talking about the project Rebuild for Resilience. So this study is also the part of the Rebuild for Resilience, and in this study we tried to explore the key elements from the resilience framework, which are circled in green. So those were like the inclusive and open decision making, intersectoral coordination, human resource management, etc. So this diagram shows the trajectory of COVID-19 policies that we studied over the time. Going to the response structure, multi-sectoral collaboration was very much evident in the response structure, and which was led by the MOHP and CCMC. Although the structure was formed from the federal to ward level, however, the ward level functionality of the ward level coordination committee and the community participation in this structure was not very much happening. On the policy formulation process, as in this decentralized system, pandemic and any emergency management falls under the responsibility of the federal government. Therefore, federal government was leading the overall policy formulation process. Only few policies were formulated by province government, while local governments were mainly implementing the policies. Despite having decision space to formulate their own policies, local government were mainly relying on federal and provincial government. Even the contextualization of the policies and directives developed at federal or province level were also not done at the local level because of the limited technical capacity. Intersectoral coordination was evident in the formulation process at the federal level with the participation of different line ministries, sectors, armed police force, etc. However, the virtual communication with the vertical communication with the subnational governments was very minimal, and when done, were largely done through virtual means and primarily with the provincial government. Gender equity and justice was another issue that was also well not reflected in the policies and guidelines. On the policy communication, various channels were used, such as daily situation report, daily briefing, social media sources. However, there was absent of focused, targeted communication according to the type of audiences. And all of these channels were top-down one way. This led to inconsistency in understanding and the orientation or the interaction for communicating policies from federal to subnational governments and from the local government to health workers was also not very much frequently happening. So subnational governments were less aware about the policy updates and changes, and this was also affecting the service delivery in the initial phases. At the health facility level, health workers were not always informed about the changes in the policies, and when informed, they were informed via phone and were not informed in the written form. So they felt that this approach was also not very effective for communicating about the policies. Health workers mostly relied on social media and website to get updated, and those health workers who did not have access to the internet, they were poorly informed in such situation. The chronic shortages of health workers in Nepal is very much evident, and this was also evident in both study side. Same health workers were delivering both COVID-19 and the routine health services. So this raised the issue of infection prevention and control, and the health workers working in the quarantine and isolation centers were affected by the COVID-19, which further aggravated the shortage situation. So all this led to the, resulted in heavy workload and longer working hours for health workers. So motivation and supports related policies were there. However, there were the policies regarding risk allowance, health insurance. However, health workers were also demotivated in a way because these allowances were all not reaching them on time. And when reaches, there were discrepancies between the municipalities. Some municipalities distributing 35%, while the other is distributing 50 to 100% of the allowance. So there were issues like, because of the shortages, province could not allocate leave and holidays for the health workers. Issues on physical protection were evident in the initial stage. However, with time, local governments started procuring personal protective measures themselves. So this was not an issue in the later stage. Fear of COVID-19 was there among the health workers because there were insufficient information in the beginning. And also the health workers were facing social stigma and discrimination, which were very much evident to all of us through various media sources. Later, as a reactive management, government of Nepal released directives for actions against such behaviors, and this
you have 2 more minutes,
was
please.
Not a problem. So this is my last slide. So what are the key learnings from this study? In terms of 4 areas that I highlighted, a policy formulation process, which was again not very inclusive and participatory because COVID-19 appeared as a shock to us, and the rapid policy development process had to be happen. So this did not lead to a participatory and inclusive policy development process. However, engagement of national and subnational governments and intersectoral stakeholders is crucial in order to formulate contextually tailored and evidence-informed policy. Effective communication across and between the tiers of government is often a complex process because multiple channels were used and the approach was top-down. Therefore, a mechanism need to be strengthened at different levels to ensure consistency in understanding according to the type of our audience. Mobilization of health workers. There is the absence of health resource mobilization plan, which was also highlighted by Dr. Gurnidhi Sarma yesterday when he was presenting on behalf of MOHP. So this plan should be in place. Strong leadership and commitment should be shown from the from the federal, but more particularly from the subnational and the local governments for the management, redeployment, training, and task relocation of health workers. A total account of available health workers of all cadre and at all level in an established human resource information system, and routinely updating this system is another crucial part to be managed to avoid future crises. Yes, the training and orientation of large number of health workers in short span of time proved to be a stumbling block already for the government, and thus strategic approaches, engaging multiple stakeholders, adopting innovative ways of training are the lessons to be learned for the future pandemic. And in terms of incentives and balanced incentive packages are very much important to retain and motivate health workers. So more particularly, local governments should be moving towards retaining the health workers by recognizing and appreciating efforts, providing an environment for supportive supervision, protecting their physical and mental health, and also by managing their working hours. And on top of these, the last thing is contextualization of policies is very important, and routinely reflecting and adapting the learnings that we have learned from implementing those contextualized policies and communicating them effectively to the targeted audiences is very much essential to implement any policies and to manage any pandemic or any nature of shocks in the future. With this note, I end my presentation here. Thank you for listening.
Thank you.